I'm sure most of you will know these two speakers who I have the pleasure of introducing this morning. No strangers to the very active Medify listserv and community. Dr. Laurie Regenstreif is a family doctor in the inner city Hamilton in several addiction care settings, including an inpatient consult service for patients with OUD, the St. Joe's RAM Clinic, and an outpatient OAD clinic in the basement of a church. She has a special interest in mental health and addiction care for incarcerated populations and would like to wave her magic wand and make street fentanyl and alprazolam disappear. You know what, Laurie? I think we're all with you on that one. Dr. Kahan is the reason I came to work at Women's College in the first place. He's an associate professor in the Department of Family and Community Medicine at the University of Toronto, medical director of the Substance Use Service at Women's College Hospital, and medical director of Medify. Over the years, he has written several peer-reviewed articles, guidelines, and educational publications on addiction-related topics. His main interests are primary care and addiction, opioid agonist treatment, medical marijuana, and medical education in addiction. Thank you all for joining this morning. Just a reminder to please complete your evaluation forms at the end of the talk, and I will remind you again. So take it away, Mel and Laurie.
Thank you so much, Monique. We are going to talk about methadone treatment in the fentanyl era and new consensus guidelines that we've been working on. Financial disclosures, Laurie has spoken for Indivior, the manufacturer of Suboxone and Sublocade, but we won't be talking about buprenorphine products today, and I am the medical director of Medify. But we will be discussing off-label use of slow-release oral morphine. So the background, the core writers of this guideline are us, Laurie and I, as well as Lisa Bromley, Anita Srivastava, and Jennifer Wyman. Sarah Clark, our Medify's knowledge broker, is the coordinator, the editor, and the writer that's kind of shepherding the process along. And we decided to write this guideline because I think many methadone prescribers are kind of looking on in horror with this fentanyl and a sense of helplessness. I can tell you that I've been in the methadone field for, close to 40 years. And in my experience all along with heroin and then with the OxyContin crisis, methadone was a remarkably effective drug. If people dropped out of treatment, it was usually for other reasons besides methadone. That is, they didn't like the rules, the carries, whatever, or they just dropped out for other reasons. If people were using drugs, it was almost always cocaine or something else, rarely opiates. But now we're seeing people who are on pretty reasonable doses of methadone, who are continuing to use fentanyl, and who are dropping out of treatment and who are dying. And I think our sense of horror and helplessness is probably very similar to what maybe doctors faced at the early days of the coronavirus epidemic, when you had, ICU doctors and emergency doctors and hospitalists confronted with this infection that they didn't know how to deal with. They didn't have the tools, a great sense of fear and and also grief, as we saw patients who have died and there was nothing we could do about it. I think part of our recognition is maybe this is not just the limitations of methadone per se, but we are also hamstrung by the CPSO methadone guidelines. And we realized that these guidelines were not as, they don't fit with fentanyl users. Maybe they were okay for a lot of OxyContin users, but they don't seem appropriate, and they are acting as a barrier to treatment. So we have a question we'd like to ask you. We'd like to take a poll. So if people can, Brittany, you could bring that up, the first polling question. So in my experience, oh no, go ahead, you're gonna read it. Or am I going to read it? Okay, I'll read it. In my experience, people who use fentanyl are more likely to continue to use fentanyl while in methadone treatment when compared to people who use heroin or prescription opiates. So if you can indicate the extent of your agreement with that question. I guess the results of the question will be, of the poll will be posted. Oh, there we go. 43% of people have voted.
And if you just scroll down, Mel, you'll see 26 out of 176 strongly agree, 45 out of 176 agree, and then the rest are unsure, disagree, or strongly disagree.
Okay, so a pretty good majority of people agree that people are continuing to use fentanyl while in methadone treatment. That is, it doesn't seem to be as effective in terms of suppressing opiate use as it was for patients who use prescription opiates or heroin. Okay, so on to the next slide. So in preparing the guideline, we conducted focused literature searches on core questions. How effective is methadone for fentanyl users? What is the optimal dose? Again, we focused as much as possible on fentanyl, recognizing that there's not as much literature on it as there is on prescription opiates and heroin. And we attempted to achieve a consensus amongst ourselves. I want to emphasize that this is only the first, but probably the most difficult part of the guideline. We also intend to do sections on buprenorphine, on slow-release oral morphine, and general aspects of opiate agonist treatment. And we plan to distribute the draft guidelines for review broadly by addiction clinicians and by persons with lived experience. So going back to the 2011 CPSO methadone treatment standards and guidelines, the guidelines were written at the height of the OxyContin epidemic. I and my colleague, who's also on the guideline, Anita Srivastava, were on the core writing committee. Our major focus was the prevention of iatrogenic methadone toxicity. And this explains many of our recommendations. Patients who miss 3 or more doses must be assessed in person on the phone, not on the phone before getting another script. Patients who miss a dose must remain on 30 milligrams for 3 more days before getting an increase. No increases without seeing the patient first. If the patient misses an appointment, they must remain on that dose until they are next seen. Patients on benzodiazepines must be started on lower doses and it should not receive carries. Patients on methadone should not be given additional opiates. You have to obtain an ECG before increasing the dose beyond 120 milligrams. So in our review, I think we have a few general principles. One is that the recommendations related to dose titration should be followed. Methadone is a very toxic drug. The window between a therapeutic and a fatal dose is pretty small, but all other clinical decisions should be based on clinical judgment and not on rules from the CPSO or anybody else. And in this respect, we're saying that this is like any other medication. The product monograph outlines the rules that, the dosing principles that should be followed, the precautions, the maximum dose, etc., the rate of titration, and that's very reasonable with methadone. But the rest is up to clinical judgment as, the frequency of visits, when you fax scripts, when you get urine drug screens, etc., etc. And the reason why we are saying this is that the risk of a subtherapeutic dose and the risk of treatment dropout are enormously serious. The patient who remains stuck at 30 milligrams is at very high risk of treatment dropout and fatal overdose. In contrast, the risk of iatrogenic methadone toxicity is pretty well negligible if the clinician exercises reasonable judgment. There are people dying from methadone overdose. Almost all of them are people who have taken diverted methadone, people who are not tolerant to methadone, and somebody sells them a dose of 100 milligrams or something, and they die. I have not, and none of my colleagues have heard of a patient dying directly from a prescribed methadone dose in a very long time. I'm not saying it doesn't happen, but it seems to be insignificant compared to the tremendous number of people dying from fentanyl. And furthermore, fentanyl users are even less likely to experience methadone toxicity because they have a very high degree of respiratory tolerance. So even if a patient who is on fentanyl takes a diverted methadone dose, which is not a good idea, but if they do, they're unlikely to die from it. So we think there needs to be a profound rethinking of the rules that CPSO guidelines have put forth. For example, a small example, if a patient misses several consecutive doses, why not leave a 30 milligram prescription for them at the pharmacy to pick up? They're not going to be harmed by 30 milligrams. It will give them a chance to re-engage in treatment. It will be, make it so much more easy for them to meet with the doctor and get back on track. So our basic principles are clinical judgment has to take primacy over the CPSO guidelines. We do not think that the CPSO has, has really, I would say, the moral right to arbitrate clinical judgments anymore. Their last guidelines were in 2011. They were written 10 years ago. They don't address the fentanyl crisis. And so we don't think that they are, should be telling doctors how to practice. The clinician's objective has to be to retain patients in treatment and achieve an optimal methadone dose as quickly as possible. And if that means revising our practices with regard to frequency of visits and prescriptions and so on, then so be it. So that's our kind of underlying guiding principles. I just want to go into a very central question. Does methadone treatment work for fentanyl users? And we did look at this. I think there's a certain spirit of nihilism that's overtaken our profession, the belief that methadone is a failure, buprenorphine is a failure. We have to look at other alternatives, injection opiate therapy and safe opiate supply and so on. The fact is that is actually simply not true. Methadone treatment is by far the most evidence-based and effective treatment right now for fentanyl users. We know this from observational studies, systematic reviews, and controlled trials. In a systematic review, the overall mortality rate for patients who are on methadone was 2.6 per 1,000 patient years, rising to 12.7 per 1,000 patient years while off methadone. So very, very protective against fatal opiate overdose. Methadone's protective effect may be greater in the fentanyl era than before. This is based on a study in BC which tracked mortality of patients on and off OAT right from 1993 or something to 2018. And it found that the relative risk of death while off OAT was 2.1, rising to 3.4 after fentanyl was declared a public health emergency in 2006. In other words, the protection from methadone was even greater in the fentanyl era than in the pre-fentanyl era. In the meantime, the mortality rate while on OAT wasn't higher from 2010 to 2018. Patients who were on methadone seemed to be not dying at a greater rate. And so that suggests that OAT does give substantial protection from fentanyl overdose, and other studies have had similar results. We know, in fact, from cohort studies, retrospective cohort studies of clinics, that methadone appears to protect against overdose even among patients who continue to use fentanyl. And this is based in large part on a study done in Rhode Island of 127 primarily fentanyl users who were on methadone. They mainly continued to use fentanyl even though they were on methadone, but there were no deaths, although 4 people died shortly after dropping out of treatment. We also know that higher methadone doses are more protective than lower doses. This is based on this BC study of people who actually did die while they were on methadone, a small number of people who died while on methadone, and they were mainly on doses of below 60 milligrams. Only 12 were on doses of 80 milligrams or more. Conclusion, methadone confers substantial protection against overdose in patients who use fentanyl, and it remains by far the most evidence-based and important public health strategy to address the fentanyl crisis. So now I'm going to turn it over to Lori, who will go in more detail into our specific recommendations.
Thanks, Mel. Do we have my polling question first, or is that okay? The 2011 CPSO guidelines have hindered my ability to titrate methadone adequately and offer adequate options to retain these patients in treatment. Please, if you do look after people who are on methadone, give me an answer to this statement. Your impression. Am I able to do it? There. I'm assuming there's a significant percentage of people who may not actually, in the audience, who may not actually prescribe methadone. So we're just going to assume that those who are responding are people who are comfortable and do prescribe methadone, particularly to populations where there's significant fentanyl use. So I'm scrolling down. All right, so aside from people who don't prescribe methadone, it looks like everybody experiences at least some hindrance of their ability to titrate methadone adequately. And I know this is a source of frustration both for patients and for providers. So what I wanted to do in this part of the talk was go into a little bit more detail on some of the points or key features of the guidelines that we've been working on. I think it's really important, first of all, as Mel said, fentanyl is a whole different ball game for everybody. Patients will come in and they will insist that their tolerance is so much higher, which it is. They have a much higher opioid tolerance. But the methadone molecule hasn't changed. So the molecule and its pharmacokinetics are the same as ever. It still requires 3 days to 5 days to reach a full steady state. It still requires P450 metabolism. None of that has changed, and we really weren't able to find compelling support for choosing a dose higher than 30 milligrams as a starting dose for patients when they're even when they're restarting, if they've missed a significant number of days. And again, on the same note, we weren't able to find support for increasing their dose by more than 10 to 15 milligrams per day. And despite the high potency of street fentanyl, the cross tolerance to the respiratory depressant effects of methadone is incomplete. So we know that even though people are highly tolerant in terms of respiratory effects to the fentanyl that they're using, it doesn't mean that they're going to be that much more tolerant to the effects of methadone. But we also know that people who need to repeatedly restart, so these are the ones that are rolling in after they have 2 days of 30 milligrams and they missed a day, and then they show back up and they get 2 days and they're all resolved, but they've waited those 2 days and they've gotten really no beneficial effect from the methadone. So what we wanted to do was introduce some really hopefully helpful strategies. The first one is, one of the first things we've felt confident to say is that a dose can be titrated regardless of the presence of benzos in their urine at the same schedule. So if somebody presents with benzos in their urine, all things being equal, if they're not presenting with red flags like use of large amounts of Xanax, which I know some people, I'm seeing quite a bit of in young teenagers, in young adults and older teenagers, and you're not seeing people presenting nodding off or sedated in their doctor's visit or at the pharmacy, then go right ahead and give them a 15 milligram dose increase to a maximum of every 3 days. You can choose to titrate slower if, for whatever reason, your clinical judgment prevails. So one of the other new strategies that we're now really supporting is the use of a full mu agonist, slow-release oral morphine. It's still known under its trade name Kahan. It's not the same as any of the other sustained-release morphines. It's specifically Kahan, and this is how we've been prescribing it. So Kahan, you can consider using it, and it's actually, I think it's fantastic to be able to offer it as soon as people are restarting. So as soon as they're restarting their methadone dose at 30 milligrams, you can add 200 milligrams of slow-release oral morphine that's given alongside their methadone. The prescription must say, or should say on it, witness dose daily with methadone, open capsule, and dispense sprinkles in a cup. I usually ask the pharmacist to give them the cup of the contents of the Kahan, followed by their drink of methadone. Now, 200 milligrams is a number that we've sort of borrowed from the Saskatchewan guidelines that have been around quite a long time. We've had a couple of conversations recently with Peter Butt in Saskatchewan, who was probably the one who pioneered that. Given I looked it up actually last night, the 1 point of fentanyl is roughly about 200 milligrams morphine, but then there's variability in the potency that people are using, and it's really not a good way to calculate what you should use. We've generally been developing ballparks, like if people use half a point of fentanyl every couple of days, that might be a slow to moderate amount, or low to moderate amount of use, whereas people who are using 1 to 2 points or more every day are in the higher range, and you can go upwards to as much as 300 milligrams when you're starting the methadone. You can also actually titrate the the slow-release oral morphine upwards as you're titrating up, or when you get to a certain point in the methadone where you don't feel you want to continue, and I'll get to that a little bit. The slow-release oral morphine doesn't necessarily need to be tapered down. It really depends on people's response, but I find that it's most useful in the first 2 weeks when people are finding that they're not getting an immediate benefit from their methadone dose or from their methadone dose increase, because it'll take 3 days for that to happen. Whereas with the Kahan, they're getting they're feeling the impact or some benefits from the Kahan within the first 12 to 24 hours. And this is, first of all, more likely to have them continue to return for further doses, and more likely to have them show up for follow-up visits. So the next big departure for us has been establishing that for patients who miss 3 doses and present on day 4, they should be continued on what their current dose is. That even if it's 100 or 120, if they miss 4 days, they can continue on their current dose. For 3 days, they can continue on their current dose on the day 4. The risk of them drifting off of treatment and having to restart at 30 and going off and using fentanyl and relapsing to higher amounts of fentanyl use are much, much higher than the risk associated with allowing them to have their dose on day 4. If they miss 4 doses and present on day 5, their dose will need to be reduced. So for example, if they were on 100, they'll need to be given 50 milligrams and then titrated up. It would otherwise be 30, it depends on which is lower. The other thing we're suggesting is, and this is a sort of a second component to this, is for people who are going through the titration period and are missing doses but are getting many of their doses. So if you give somebody a week's worth at 30 milligrams and they get 3 out of 5 previous days and show up for a dose increase, or 4 out of 7 of the previous days and show up for a dose increase, we're encouraging people to continue to titrate up their methadone dose unless they've missed the 2 previous days, in which case we recommend that you give them the dose that they were on and then schedule an increase for the following 1 to 2 days afterwards. Again, we recommend using clinical judgment when there's presence of benzos. So another departure that Mel referred to, I think, was missed appointments. So we feel very strongly that if people are missing appointments but they're showing up consistently at the pharmacy, there are ways that you can arrange for them to have a dose increase, or at least provide extended prescription until a patient can be seen. We don't recommend patients continue to get dose increases without a visit to the prescriber, and we don't recommend necessarily that doses continue to be increased without a visit to the prescriber once they've hit 80 milligrams. But we don't recommend that that you taper off or hold a prescription or cause people to miss a dose just because they missed an appointment. We consider this to be punitive and unfair, and it puts people at much, much higher risk of falling off the program, and really your goal is to retain people in treatment. So we say never stop a methadone script for a missed appointment. If a patient is dosing regularly, even consider contacting the pharmacist and asking them to look out for the patient, to pass a message on saying you'd like to see the patient in the next week, and make sure there's an extending prescription. Have lots of communication and bridge your communication with the pharmacist. So as I said, work with the pharmacists. Most people have a couple of good relationships with at least a handful of pharmacists in your community. We should be relying on pharmacists to be able to identify a patient who has missed 4 doses. Obviously, that's their obligation, is to hold a prescription and contact us. As well, if a patient is showing up intoxicated or sedated in the pharmacy for their dose, the pharmacist is obligated to hold their dose at that point and contact us. And this is probably as effective, if not more effective, than insisting on a patient come in to see us, but at the same time withholding their prescription. Take-home doses, we've got slightly different opinions about this than the pattern of our less conservative approaches. We still consider take-home doses should be looked at with caution. There's a panel this afternoon that will talk about COVID-related changes to take-home dosing scheduling, and we won't get into that. But for people who have stopped using their fentanyl and are stabilizing in other aspects of their life, so they've perhaps got stable housing and are reestablishing some work obligations or family relationships, we recommend that they can choose to participate in a contingency management program with either random or regular urine drug tests, and that no take-home doses be provided in that first month of stabilization, and also that stabilized patients perhaps who have regular take-home doses for work or travel could consider a transition to buprenorphine, which is a safer drug for take-home dosing. Urine drug testing. So urine drug testing is limited. The benefits we get from doing it are limited, and decision-making is probably most important with urine drug testing just at the very beginning of starting and titrating methadone in the first weeks. For example, if somebody presents as sedated and they have benzos in their urine, or there's a concern that they've been using street Xanax, again, that's a big thorn in my side, you may make a clinical decision about the dose that you give them or the titrating dose you choose for them based on that. So patients requesting a dose change or with a history of significant benzo exposure, perhaps you do want a urine test. But for patients that have stopped their fentanyl use and achieved social stability, for patients who've stopped their fentanyl use and are stable, you can use contingency management, urines for contingency management, as well as for patients who request regular testing for their own knowledge, for their own education. I find it very helpful to discuss a urine test with somebody if it's, for example, has a contaminant such as levamisole, which is a contaminant common in cocaine, or if they want to know whether there's fentanyl in what they thought was a heroin supply or an OxyContin tablet, or if they have a vigilant spouse, or if CAS or probation and parole is involved. But in other contexts, there's really no benefit or reason to be using urine drug testing more often than once a month. For people who are on a stable dose of, let's say, 80 to 120 milligrams of methadone, there's probably no reason at all they need to have their urine tested more than once a month. And even that, it will depend again on clinical judgment. And certainly in the time of COVID and regional lockdowns, it's really helpful to be aware that you can sleep at night even if you haven't tested somebody's urine in the last week. So another situation that we've drawn from is I know I have a few patients who choose to stay around 30 or 40 milligrams, and they always say, no, I'm fine, I don't want a dose increase. And when we ask them, they admit that, well, when they take a dose increase, it blocks the effects of the fentanyl, and they're very pre-contemplative about stopping fentanyl. However, they're still participating in OAT treatment. And I've been very transparent with people, especially after going through all of this data, to emphasize that it's protective and it's better for them to be in the program than not in the program. And we also encourage people to accept dose increases. Even small dose increases are 5 milligrams or 10 milligrams from time to time every few weeks, and encourage them with the knowledge that we've seen that doses over 60 are probably more protective for them, doses over 60 of methadone. You could also consider for people who really do not, I have a patient right now who really was not comfortable going over 50, he wanted to go back to 40, so I offered him some Kahan, and he's now on 200 milligrams of Kahan in combination with a low dose of methadone, and he much prefers that because I think he feels the Kahan has less of a blocking effect for the fentanyl. However, it helps maintain his tolerance. And again, some of this is clinical judgment. I have a bit more experience now with Kahan. For many of you, that may take some time, but we really encourage you to start considering these new approaches. Quick question about ECGs. I think it was either 120 or 130. For higher doses, we've been encouraged to obtain a 12-lead ECG whenever possible. That being said, if somebody's continuing to use fentanyl and they require a dose increase, we encourage you to increase the dose, even if you can't get an ECG, because the risk of torcetrapin is quite rare compared to the risk of fentanyl overdose and the other risks related to ongoing fentanyl use, especially injection fentanyl use or injection drug use for people on methadone. If there is a history of prolonged QT or they're on a QT prolonging medications, then it's reasonable to hold your methadone dose increases and again add slow release oral morphine instead to help reduce their ongoing cravings and perhaps some of their fentanyl use. Slow release oral morphine does not affect the QT. And really our overarching goals are to adopt practices that promote treatment retention and reduce barriers to treatment reentry. So leaving a prescription for somebody's dose, whether it's 30 or 45 or even 60, and they're not showing up for appointments, but they're showing up to the pharmacy, is encouraged. And the frequency of their visits to the doctor should be really based on clinical need and need for you to make decisions or for them to make decisions about changes to their treatment, not on a fixed schedule like every week this person has to come in and sample and see the doctor. And this is where treatment is life-saving. This is where we feel that if you can retain people in treatment, then that's really life-saving compared to creating a very rigid and structured program that is very difficult for people who have a lot of chaos in their lives to comply with. And simply reducing the number of injecting events by providing oral methadone is an approach it's a harm reduction and risk reduction approach. So in conclusion, long-acting opioid agonist treatment is life-saving. It's a life-saving intervention. Oral opioid agonist treatment allows people to reduce their risky fentanyl use, to reduce the frequency and the desire to inject opioids. People who use fentanyl have high opioid tolerance, but methadone is still a risk and it still requires some cautions. I know many of my patients had asked me, why can't we start at 40? And I said, I promised them I would find out for them. And I feel like we have. The goal is to encourage retention in treatment. And that doesn't mean encouraging returning to your clinic from time to time, but rather maintaining somewhere on the tier of recovery, maintaining their doses at the pharmacy. Expedite dose increases, provide prescription extensions, educate the patients on why you make the decisions you make and why you're concerned about their the benzo in their urine, for example, or why you don't think that you think it's too early for them to have a dose increase. And just encourage re-entry and facilitate maintenance by ensuring that their prescriptions are renewed, even when visits are missed. So Mel's already acknowledged everybody that was involved so far in this document. Sarah Clark has been incredible. Kate Hardy supported her as well. And again, in addition to Mel and myself, Lisa Bromley, Anita Srivastava, and Jennifer Wyman have all been very active all summer long, reading a lot of papers and exchanging a lot of emails, trying to generate something that we hope will be a really helpful document for people who look after individuals who are having difficulty getting stopping their fentanyl use. I think that's my last slide, and we can go to questions.
There's quite a few questions on the chat room. Yeah.
I can imagine.
Yeah.
Well, we'll get right into it. Given that illicit fentanyl has been present in an astonishing number of overdose deaths in Ontario for a number of years now, why do you think that the CPSO has allowed its regulations to remain so dangerously out of date?
Yeah, I can address that question. I think that it wasn't sort of a deliberate decision. It was just inertia. The CPSO has decided to get out of the guideline business. There really isn't, as I understand it, a formal methadone committee in the CPSO anymore, although they have several physicians who are considered to be expert or specialists who are also on CPSO roster. So they just kind of let it linger. They don't want to be in the guideline business anymore. That's fine, but what they haven't done is said, in essence, liberate doctors from the old guidelines. They haven't said, use your clinical judgment. You're free to practice in an independent way like any other area of medicine. So, my feeling is that's an abrogation of their responsibility. Either they come up with new evidence-based guidelines that fit the new situation, or they tell doctors that the 2011 guidelines are no longer valid. But they're not doing either. And I think that's wrong. But I don't think there was any decision on their part. They just, it's just inertia.
Thank you for that, Mel. Next question is, what is the mechanism of overdose protection with concurrent use of fentanyl, given methadone is a full agonist and doesn't have the same protective pharmacology of buprenorphine?
Oh, yeah, I could take on that question too. Methadone works by building tolerance. And so tolerance to the different effects of opiates develop at different levels. We never develop tolerance to the constipating effects or GI effects of opiates. We develop tolerance very quickly to the psychoactive and sedating effects of opiates within days, really. And we do develop respiratory tolerance, but it's somewhat slower. It can take weeks or months. And even then, that tolerance isn't fully complete. So tolerance is an adaptation of the receptors in the central nervous system so that, you basically resist the effect that other people who haven't taken the drug are getting. So what that means is a patient who takes 100 milligrams of methadone in the morning is going to be okay. They're still going to be able to breathe. There is a little bit of suppression of their breathing and blunting of the CO2 response, but they're basically okay. Whereas if you gave 100 milligrams to a naive patient, they would die. But there's also cross tolerance. So tolerance to the respiratory depressant effects of methadone is transferred to fentanyl. So when they take fentanyl, they're relatively resistant to this, putting the coma-inducing effects of fentanyl and also the respiratory suppression. So it is a different mechanism than buprenorphine. Buprenorphine also works to some extent by tolerance, but it mainly works by blocking the attachment of the opiate to the receptor. Methadone doesn't block the attachment of fentanyl. It just allows the central nervous system to resist it more.
I'm going to add
great.
one.
Thank you, Mel.
I'm just going to add one quick thing to what Mel said, and that is that we forget that if people are not on a long-acting oral opioid agonist, and they're only using short-acting agonists, they will have periods of abstinence that can go anywhere from some number of hours to a couple of days. They may switch over to stimulants for a period of time and lose that opioid tolerance. And in fact, I've seen this quite frequently. People will simply say, no, I've just been using, crystal meth for the last week. So they may have lost their opioid tolerance completely and then simply go right back and use some fentanyl again. So not having that long-acting effect is what's also missing when people are using short-acting opioids, or when they're injecting long-acting opioids like Kahan, which can happen as well.
Great responses. Thank you both for that. Julie Sampson asked, can this evidence be applied to Suboxone as well?
The answer is yes. There is also good evidence that Suboxone reduces the risk of overdose in opiate users, or at least a fatal overdose. Observational studies and a very large systematic review found that as well. I think the Suboxone does not appear to have as good a treatment retention rates as methadone, and that's been consistently shown in randomized trials and systematic reviews, although it is far safer. So we have done the Suboxone section, or the buprenorphine section, but I think we're going to recommend that Suboxone can be tried when appropriate because it's of its safety. But if a patient, you should quickly titrate to the optimal dose, 24 or 32 milligrams. If the patient continues to use fentanyl or drop out of treatment, they should be switched to methadone. Sublocade or depot buprenorphine has a higher buprenorphine level and may have better treatment retention rates than buprenorphine itself, but I think we still have to assume that methadone is more effective. So methadone needs to be something that we quickly return to or turn to if the buprenorphine isn't working.
Okay. Biggest issue is missed doses. I've seen clients prescribed and miss even the first dose and maybe only dose every other day. Wondering if Sublocade is a better option if putting effort into those first 2 weeks to get someone stabilized.
Laurie, why don't you take that one?
So I think if I understand the question, it's so people who are only getting a methadone dose every other day, for example, in a week, would they be better off switching and getting onto Sublocade? I wouldn't say so. I would think that you can set up strategies. Again, it's important to look at why are they missing so many doses? Are they having to come in every 3 days? So is somebody just writing them a 3-day prescription saying, okay, come in on day 4 and get a dose increase, rather than here's a week. If you get 3 days in a row, come in for a dose increase, or now 4 days in a row. 3 days in a row. But I don't think that our system, that what we're providing has been flexible enough. And I think that's the issue. I would definitely start methadone, and you can add Kahan. This can help a lot as well. If people know there's some Kahan as available to them, then they're going to have some benefit that very first day. Whereas they know in their mind, yeah, that 30 milligrams is not going to touch me. I don't feel it. They will feel the Kahan, and it will be an incentive for them to go back the next day and again feel better even after their second dose. So I'm a big advocate of the combination.
Thanks for that. Peter asked, will we get pushback from pharmacists?
I have a little bit, but it doesn't take long. Eventually, I think your pharmacy community starts, like they have their own word of mouth as well. We have very few pharmacists where, was that pushback about, I don't think I know which one, like about the Kahan or about the methadone dosing?
I believe about the methadone dosing.
Yeah, and let's assume either one. I think it's just a matter of writing information on maybe a note on the prescription when you first do this. I don't know if I've had any pushback on methadone dosing. I did once restart somebody at 40 because they had I think it was three days of 30, then missed a day or something like that, and I didn't get pushback. But you may need to educate the pharmacists and write little notes on the prescriptions, which is usually my strategy.
Okay, Great. And Robin asked, what is the legal implications of providing scripts to those who are missing appointments?
I could address that. I think we do it all the time, right? I mean, if a patient misses an appointment and they're on cardiovascular drugs or diabetes drugs or antidepressants, we almost always refill the script. So I think it should remain on clinical judgment. In terms of legal implications, I suppose the college, this is in contravention of their guidelines, but I think that if you document and say why you're doing it, I think it would be, I can't imagine the CPSO coming down on you. I think it would be outrageous if they did, and there would be huge pushback. So that's all I can say. I think we need to do what's right for our patients and not worry about the CPSO at this point.
I think the legal risks of not continuing a script or not extending a script for somebody, the ethical risks around that together far exceed the risk of extending somebody's prescription.
Yeah, that's a good point. Yeah.
Dr. Sam Young says, do these new guidelines support initiation of methadone in the absence of urine drug tests, particularly if well-documented fentanyl use? Given COVID and many of us doing virtual care, I feel this is important.
Lori, do you want
to?
Sure.
Documented fentanyl use, yeah.
My knee-jerk response is yes. Yes, people don't make up their fentanyl use. Methadone is not a desirable drug, especially if you have to ingest it. It might be challenging if it's somebody you don't know at all, but I have done lots of telephone assessments and started people on Suboxone. So, if all fails and you're not comfortable doing a telephone assessment with somebody and starting them on methadone, you could start them on a microdosing protocol of Suboxone, and then once that failed, rotate them over to methadone. And at that point, that they're opioid tolerant because you've been giving them Suboxone for some period of time. But other than that, I would say we're going to have to be prepared to not have to do urine drug tests on people. And I don't find that there's the number of false negatives in urine drug tests. Half the time people are on clonazepam, we don't know because it doesn't show up in a point of care test anyway. So I don't find urine drug testing, I think it's important for certain things, but we need to recognize the limitations of it.
Right. I think that in a system that made sense, both Suboxone and methadone and Strom would be able to be started in inpatient settings, EDs, and hospitals, where they may not have access to point of care fentanyl tests. If you had a patient who was in the hospital and they were an opiate use disorder patient and you couldn't start Suboxone for whatever reason, I would think it would make total sense to start methadone 30 milligrams. You're not going to hurt the patient, and even if they're not going to be lying about their fentanyl use, and even so, 30 milligrams is a very safe dose. Absolutely, I would do it. If access to point of care testing is not available, for sure, I would recommend starting methadone.
Okay. Regarding missed dose appointments and continuing dosage, should this be the same approach if the substance is Suboxone opposed to methadone?
No, the Suboxone should be much more flexible than methadone. The guide, I think, for Suboxone is fairly reasonable. I think it's, I have it sort of a template in my charts, but they have to miss 5 days in a row and of a certain dose, or even 7 days if they're on a higher dose. So it doesn't apply to buprenorphine. Right.
The difference is that you could give buprenorphine, 12 milligrams or 16 milligrams, and it would be safe, no matter how. So basically a therapeutic dose right off, but you couldn't give 100 milligrams of methadone to someone who had missed, a week or something. It would not be safe.
Okay, great. Is the goal to use Strom to bridge between dose increases or titration to stability, or as a part of maintenance to reduce cravings long term?
That's a great question, and thank you whoever asked that, because it's something I turn over in my own head all the time. It really will be patient dependent. I find on one hand, it's a strategy for people who are constantly missing either that third day, or they're missing a lot of appointments, or they're just people who are less, we know that they're less likely because we've been looking after them for a while. Those are the people I think we can start with, at least, to offer them SROM. And then as their dose of methadone, they get successful. And I've had this happen a number of times. They get to 60, they get to 80, they get to 100. I often will start trying to lower it, and usually people don't mind or they don't even notice. But if they get down under 100, I have one patient who feels much better with 50, plus I think they're on 100 or 80 or 100 milligrams of methadone. I just keep it going. Sorry, I'm getting a message here. It's only going to be beneficial if they've stopped their fentanyl use. And it's observed dosing, right? So it's not like it's divertible. The most important thing I think I mentioned is that the Kahan capsules need to be opened and served, because Kahan only dissolves in cold water. I've gotten the lowdown from all of my patients. It dissolves in cold water. That means they're making a cold water solution and it's being injected, which is really dangerous. And I've had a patient begging me to give him Kahan in capsules so that he can inject it, because that's what he was doing. He was diverting it when he was in a care facility for a while. And he ended up with candidemia. I've seen a couple of cases of that. And I explained to him it's because mold grows on the sponge and mold grows in the cooker. And when you're putting cold water in there, you're not killing that mold. And there's just no way around that. So that's just an aside about Kahan and safety of Kahan. We have about 5 minutes to wrap up. Okay, I just got the same message.
Maybe time for one or two more questions.
Yes.
Oh, there you are.
Sorry, I was on mute.
Maybe.
I think maybe one more question. So Kate asked to discuss the co-titration of methadone and Kahan and how to manage Kahan missed doses.
I don't change the Kahan dose if somebody misses a dose. The Kahan is really partly to replace the fentanyl deficit that you're trying to create, rather than a separate. It sort of goes with the methadone. So if somebody misses a dose of Kahan, if I line them up with a week's worth of 30 milligrams of methadone and 100 or 200 milligrams of Kahan, and they miss a dose, it doesn't matter. The next day they should still get 30 and the same dose of Kahan. Is that helpful? Again, people will have to start to get comfortable with this drug the same way we all did with methadone. I was very anxious and nervous about methadone when I first started prescribing it, and it will take a little time. But the patients will, first of all, they'll appreciate that you're trying to help them feel better faster, and they'll give you feedback. And you will see, like, if you're going to use some urine testing to see if or you feel you need to use urine testing to get an objective measurement of a decrease in their fentanyl use, you can see it.
And maybe just to add to that, one last one, Katie asked, for a much less experienced provider, are there Kahan guidelines for dosing? Of course, you recommend to get up to snuff with these topics.
I think we're working on that, Emil. We have...
Yeah, I mean, CISAM guideline, there is a specific guideline for slow release oral morphine, but that guideline is for SROM alone, not combined with methadone. The Saskatchewan guideline. Oh, okay.
Yeah.
Yes, there are guidelines from CISAM. They recommend that SROM be used as an alternative for patients who have failed or, on methadone and buprenorphine. They recommend that it be prescribed by experienced addiction prescribers. The starting dose is usually up to 200 milligrams, and then it can go up to 1,500 milligrams. That's not uncommon. But yeah, I would check out those guidelines.
Okay. And maybe lastly, are these new guidelines for all methadone patients or just fentanyl users? Thank you.
Great question. I think we really intended it for primarily fentanyl or injection opiate users in general. I think that the for a prescription oral opiate user, like someone who's using oral doses of Percocet or OxyContin, who isn't injecting, I think some of the urgency around getting to an optimal dose is somewhat less in our experience. So we're not saying that you have to follow the college guidelines there either. I think that a lot of the points we made are applicable to those patients as well, but we think they are particularly urgent and salient for fentanyl users.
And just in my experience, people whose problems have been with prescription opioids and only oral almost always do really well with Suboxone, with buprenorphine.
Right. Good point.
Okay. Well, the time is now 10:30. Dr. Regenstreif, Dr. Kahan, thank you both so much for that very informative talk. I think everyone learned a lot. There are quite a few questions, so I imagine you'll probably get some emails shortly after this. So I think now we have a break. I'm just going to take a second to remind everyone to complete the evaluation forms, and we will reconvene at the next sessions at 10:45.
Thank you.
Thank you.
Thanks, guys.
Thanks, Monique.
Thank you.